I just want to take a quick opportunity to thank you guys for being here this morning. For those of you that have been with us for a while, you guys may remember about 20 years ago, there were about 30 brave souls in a classroom across campus on a morning similar to this, except the heat wasn't working. And I thought to myself, what have we gotten ourselves into? Why are we putting on this symposium? Why are we doing this? I'm crazy. I still may be crazy, but we are super, super grateful that you guys are here, that we've continued to have the opportunity to put this on year after year after year. And if you'd asked me 20 years ago if we'd have 150 people in a room, 150 athletic trainers in a room for a sports medicine conference at Trinity University, I'd have probably told you were crazy. But again, thank you guys for being here. Thank you guys for continuing to support us. We're excited about this year's program. Dr. Schmidt told me to tell you sorry that he's not here this morning. He was originally going to do our welcome, but you got me instead. And you guys can take that up with him later. But again, thank you guys for being here. Our first speaker this morning is a physician and a comedian, apparently. And we're looking forward to more jokes as the morning goes on. But I'm going to go ahead and turn it over to Dr. Rush this morning. Thank you.
Woo. Thanks, guys. All right. Y'all, you hear me okay? Perfect. All right, well, thanks for having me. I think this is my third year here, so thank y'all for letting me come back. My name's Jeremy Rush. I'm a orthopedic surgeon over at Sports Medicine Associates. I've been back here in San Antonio for about 3 years, about 2.5 years. I think I know most of you guys, but for those of you I don't know, it's nice to meet you. This is probably the most important slide, in my opinion. It's got my email, my cell phone number. You guys, please take that. If y'all ever have questions or concerns, please text me or call me if you're Rodney Murray. You guys feel free to reach out to me at any time. And then I put my Instagram on there as well. I'd love it if you guys followed me on Instagram. I feel really stupid saying that, but I'm trying to get more followers. I'm almost up to 1,000. I'm really excited. So I'm going to talk about shoulder injuries, and I think I've got 45 minutes. All right, I started my timer just to make sure I don't go over. I was initially tasked with talking about shoulder and elbow injuries, which is a huge topic, and I kind of started working on that and found it a little daunting, a little overwhelming to cover that. That's basically, it's multiple textbooks when you talk about shoulder and elbow injuries in the athlete or the young athlete. So we're going to focus on some of the most common shoulder injuries that I see, and I think you guys see as well. And then one injury that I put in there that is an important one, it's not very common, but I just want to draw your attention to it so we don't miss it. The conditions we're going to talk about, high school, middle school. I know most of you guys deal with the high school, college athlete, professional athlete, but I know most of y'all see middle school kids, and they're certainly high schoolers that still have open growth plates and still kind of behave like that younger individual. So it's going to kind of cross the spectrum, if you will. So yeah, let's jump into it. So the thing I started with was clavicle fractures. I think this and shoulder dislocations are probably the two most common shoulder injuries that you guys see and I see. The other thing that is really interesting about clavicle fractures is there's been a big swing in treatment over the last 10 or 20 years. When I was a resident, which was not that long ago, we fixed a ton of clavicle fractures. And I really enjoy operating on these. It's a really fun surgery for me. But over the last 20 years, because of the literature, because of studies, we're fixing less and less of these because honestly, they don't really need to be fixed. And at least once a week, I get an email or a text from an urgent care doc or an ER doc with a clavicle fracture. And it's usually something along the lines of, this looks horrible, I'm going to send it to the ER, it needs to be admitted. Are you going to fix it tonight? And it's an opportunity to kind of talk about, these are the indications for surgery. This is what needs to be fixed. This is what does not need to be fixed. So anyway, we'll get into it. All right, clavicle fractures. Clavicle fractures represent about 15% or so of fractures that we see in this patient population. We know that the majority are mid-shaft, but you can have lateral injuries, especially in the younger athlete, lateral fractures. And you can have medial growth plate fractures as well. We'll talk about that a little bit later. We know that the clavicular diaphysis, the clavicular shaft, is the very first bone to ossify in utero. Kind of a neat trivia question. But the medial physis, the medial growth plate, is actually one of the last in the body to completely fuse. So the clavicle shows up super early when we're young, and it doesn't completely stop growing until we're in our mid-20s when that growth plate finally closes. The highest rate of growth is usually around the age of 12 or 13 in these patients. So mechanism of injury for us in this room is usually a fall onto the lateral shoulder with kind of that axial compression. You can certainly have a direct impact with a lacrosse stick or, football injury or something along those lines. But you guys will also see these in higher energy mechanisms. So ATV accidents, MVCs, motorcycles, falls from height, things like that. I think it's very important to think about associated injuries, especially in the high energy mechanisms. Now, when you have a bad car accident, bad motorcycle accident, you got to think about rib fractures, scapula fractures, pneumothorax, brachial plexus injuries can go hand in hand with these, especially in that higher energy. The other thing, and I've got a couple slides on this later, is always think about the sternoclavicular joint as well. I'll say that again. If you have a kid and you're like, hey, I think they've got a clavicle fracture, they've got a clavicle injury, it's a clavicle mechanism, but I don't see a clavicle fracture, always keep in the back of your mind that sternoclavicular joint. So on your exam, patients usually hold the affected arm with the other arm. You'll often have that deformity, you'll have the bump, swelling, ecchymosis, skin tinting. And when I think about skin tinting, there's a difference between a bump, which they all have, and true tinting, where you have, threatened skin, the skin is blanched, you don't have good capillary refill. That's what I think about when I think about skin tinting. The other thing that's kind of important to think about is with any fracture, once the bone is broken, the fracture tends to deform in kind of a classic manner. Now with midshaft clavicle fractures, you almost always see superior elevation of that medial fragment. So the classic appearance is the medial fragment's kicked up, lateral fragment is either kind of neutral or kind of depressed. And the reason why is your sternocleidomastoid and all your strap muscles from your neck attached to that medial fragment, and that's why you get that medial elevation or superior elevation. And then your lateral fragment is still connected to your coracoid with your CC ligaments, and you have the weight of the upper extremity, so usually the lateral fragment is depressed or kind of neutral. But that's what gives you that classic appearance. X-rays are usually a two-view. We usually get a two-view X-ray, which is an AP, and then a 45-degree cephalic tilt. And then if you're ever worried about the sternoclavicular joint or an atypical AC joint injury, then I would recommend a CT scan for your next diagnostic exam. So non-operative treatment. The indications for non-operative treatment, and again, this is a little, I wouldn't say controversial, but this is definitely in evolution. The classic number that is thrown about is shortening of 2 to 2.5 centimeters. Now, I'll show you guys a paper here in a minute where that may or may not actually be true, but that's what I was taught as I was going through training, and that's what a lot of us, surgeons kind of use, is if they have a complete fracture and it's overlapped by 2 to 2.5 centimeters, think about surgery. Again, may or may not be true, but that's kind of classic thinking. Certainly, if a patient doesn't have absolute indications, you can think about non-op treatment, and we'll talk about those absolute indications on the next slide. So protocol for non-op clavicle fractures. And again, I do not have a monopoly on this. If you ask 10 different doctors, 10 different surgeons, you'll get slightly different answers. So don't get hung up on this, but this is what I do. This is what I do. I usually keep them in a sling for about 2 weeks. Ice, I still use ice, but ice, anti-inflammatories, Tylenol, keeping them in the sling for about 2 weeks. As their pain starts improving, I let them start doing more range of motion, but I still had them use the sling when they're outside of the house, especially at school, to remind their buddies to be careful, to give them a little support. They begin ADLs, range of motion exercises. I see them in clinic at the 6-week mark, make sure we have some healing, some callus formation. And at that point, we start some light strengthening, light conditioning, plus or minus PT. But we start kind of moving them along when it comes to their range of motion and strength. I don't let these kids go back to contact sports, football, ice hockey, rugby, mixed martial arts, jiu-jitsu, if they're a keeper in soccer. I don't let them go back to contact sports until around the 12 to 16 week mark. And I want solid healing, pretty normal exam. The reason why is there's a pretty high incidence of refracture if you let them go back too early. And we know that they get a bump. They get a bump right there where they heal. That bump tends to remodel and decrease in size over about 6 to 9 months. The non-union rate is pretty low. It does happen. I actually have a kid I'm treating right now for a non-union, but the non-union rate is reported to be around 1 to 5%. So surgical treatment. So when do we treat these operatively? So the absolute indications are an open fracture. If it's poking out of the skin, we're going to take that, wash it out, and fix it while we're there. If they have impending skin compromise, and I'll show you a case example of this here in a minute, or associated neurovascular injury. And in those relative indications, like I mentioned earlier, significant shortening. The other thing I think about is polytrauma. If you have somebody who's got a clavicle fracture, a scapula fracture, maybe another upper extremity fracture, sometimes we're more aggressive surgically just so we can mobilize them a little sooner. The surgical treatment is open reduction, internal fixation, usually a superior or an anterior plate. An anterior plate may have less soft tissue irritation, which is one of the big risks. A big risk with surgery is prominent hardware. You guys have all seen this. That superior plate, especially in a skinny guy or a gal, can be pretty prominent, can be troublesome, especially if they're wearing a backpack. The other thing, surgery is not benign. The other thing is these little nerves called the supraclavicular nerves. They're very thin, and they run right across your surgical field. So invariably, patients will have a little bit of dysesthesia or paresthesia anterior to the surgical incision, which can be annoying, can be more than annoying, frankly. It can be bothersome. And then refracture is a risk as well. So, one of the things I mentioned earlier was that 2 to 2.5 centimeters of shortening. That's kind of the things that, you guys have probably heard that as well. Now, over the last probably 10 years, 8 to 10 years, there's been a lot of literature that's come out. Andy Pinnock, who's in San Diego, has really been one of the big authors for a lot of this. And what they've demonstrated is that teenagers, adolescents, young patients with clavicles really do well non-operatively. They do well without surgery almost all the time. There was a really famous shoulder surgeon here in town called Dr. Rockwood. He passed away a couple years ago. But Dr. Rockwood would say if the two ends of the bone are in the same room, it's going to heal, it's going to do well. This is a pretty classic paper from that group, that clavicle study group. They had 24 patients, mean age of around 15, but I think their inclusion criteria was under 21. So they were, 14 and 21, 13 and 21. 88% of them were male, which is pretty typical for this population or for this injury. The mean follow-up was 6 years, and what they found was every single fracture healed. No patient required a secondary surgery for non-union or shortening or malunion. And these patients, you followed them, they had significant remodeling of their fracture. And I think the key number is that shortening number that we hear about, that overlap. The initial shortening was over 2 centimeters. That was the average across the patient population. And they found that at final follow-up, that shortening had decreased to about 6 millimeters. So patients really remodeled, really did well. They also had improvement in superior displacement, and 72% of their patients had greater than 2 centimeters of shortening, and every single one of them had less than 2 centimeters when they got final x-rays. So what this paper tells us is that you can treat most of these non-operatively and they're going to do great. This was one of the, and I like this picture. I've actually got this saved on my computer because I like showing it to patients. This is one of the patients from their study, This is that overlap. This is what we're talking about with shortening, right? So mid-shaft clavicle fracture. This one was shortened 3.5 centimeters. I'm not gonna lie, if I saw this kid in clinic, I have a hard time not operating on it. You know, you see that, parents see that, it looks horrible. Most parents want that to be fixed. So my job and y'all's job to help me is to talk to parents and just kind of give them that, you know, heads up of, hey, this looks horrible. Look at the, you know, parents are not idiots. Look at that x-ray, it looks miserable, it looks horrible. But it's gonna heal, it's gonna remodel, it's gonna do okay. This same patient at final follow-up, this is the injured side, that's the uninjured side. The final shortening was less than 1 centimeter. You see they've got a little bump. You know it's broken. It was broken at some point, but this kid did fantastic, went back to full sports. The other thing that I tell patients over and over again is, yes, you're gonna have a little bump. A bump is better than a scar and a plate. And that's, you know, just my opinion. And even that 2.5 centimeter number, so there was a follow-up study, same kind of cohort and same study group. They looked specifically at their athletes who had more than 2.5 centimeters of shortening. So like that picture I showed you. They treated about half of them operatively with ORF and about half of them without surgery. And what they found was there was no difference in non-union, delayed union, malunion, return to sport, refracture. And the only complication difference was the patients with surgery had a higher risk of needing the plate taken out, higher risk of plate complication, obviously, higher risk of paresthesias, dysesthesias. The only thing that was a little different was they let their operative kids go back to sports a little earlier. So about 3 weeks earlier in the operative group compared to the non-operative group. But there were no differences in the patient-reported outcomes between operative versus non-operative. So, and we'll try to make this as interactive as possible. Any questions so far? Anything that we can answer about clavicle fractures? Yeah, shoot, please. Uh-huh. So that one in that study was 6 years. That was correct. Correct. Well, that's just when the x-ray was taken. That study, they called those patients back in and said, hey, let's see what it looks like now. We don't usually do that. I usually, when I cut these kids loose for sports, I don't see them back. Now the parents who are really worried, and you guys have all seen that, if they're really worried, I'm like, yeah, come back in a year and we'll get an x-ray and we'll show it to you. And I've certainly had a few of those. But usually we cut them loose, they go back to sports, and we don't see them back. Yeah. That one was for that's for academic purposes. They pulled those kids back in to see how they were looking. Yeah, yeah. Good, yes, sir. Just simple sling. Yeah, simple sling, simple sling. They've looked at that specifically, a figure of 8 brace, Valpo brace, simple sling, shoulder immobilizer. There's really no difference. I use a sling. If a patient comes in with a figure of 8 brace and they're doing okay, I don't change it. If they want to try a figure of 8, I let them. It really is. That brace is not doing anything to hold the fracture. It's not like a cast for a distal radius. It's there just to provide some support, pain control, and really for, you know, high school knuckleheads is to remind people around you that you're injured. So I'm a sling guy, but if they're doing well in a Valpo or a figure of 8, I think that's fine. Good question. Anything else? Yes. Not really. That protocol, like 2 weeks, I'm like, hey, I think that's about the right time. But if you get feeling better, take it off for showers, test it a little bit. I'm more strict about no heavy lifting, no high risk activities, but it's not a strict, 2 weeks. I definitely 100%. You want them washing themselves. And in my younger patients, I see kids all the way down to, birth injuries with clavicle fractures. Those kids are amazing. They're like little geckos, You'll see them 2 weeks later. They'll have a fracture and they'll come see me 2 weeks after the injury. You get an x-ray and it's almost healed. So that time to union definitely decreases as we get younger. Good. All right. Yes. Yeah. Yes. So avoiding NSAIDs for non-union. I I think that's a good point, and I think it's not a hill, not a hill I would die on. I know some people are big NSAIDs, some people are not. I still use them. I still like them, and I still use ice, even though King came in and he's staring at me. I still like ice. I still like anti-inflammatories, but six one way, half a dozen the other. The adult literature, especially with spine fractures, spine fusions, they talk about NSAIDs having a higher risk of non-union. I have not seen that in younger patients. So, all right, I wanted to show you guys just a couple examples of patients, and a couple of these they're all real patients, obviously, and a couple of them I think might be some of y'all's. And just to kind of talk about why I did what I did. So 12-year-old male, wrestling, mid-shaft fracture, not that displaced. I think everybody in the world would say that doesn't need surgery. I would argue if a surgeon fixed that, it's malpractice. That fracture is going to do great. It's going to do fantastic. I would argue if you had a surgeon that did an ORIF and there was any complication, I think that's malpractice. I guess I'm being recorded. I shouldn't say that. But this is 6 weeks later. So you asked about follow-up. So this is 6 weeks later. You see the fracture. The fracture actually displaced a little bit more, but you see all of this callus, all of this new bone formation. At this point, he has a little bump, but this kid has full range of motion, no pain. He's doing great. And then this was 12 weeks later. So just between 6 weeks and 12 weeks, you see the contour of the bone coming back. You can kind of imagine where the ends of the bone were, but this kid's doing great. Don't fix that. Don't let anyone operate on that, please. 13-year-old, football. This one's a little more superiorly angulated. When the ER doc called me, they said, hey, this looks horrible. This kid needs surgery. It's poking through the skin. It was not poking through the skin. It was just a bump. This kid I also treated non-operatively. This was 3 months later. So you see that that superior angulation has already started remodeling, full range of motion. I think this kid was baseball. I actually let him start getting back to baseball at this point. 15-year-old, this is actually a Smith Valley kid. And for HIPAA purposes, no, obviously we're not doing name or date of birth or anything identifiable, but I thought it'd be nice for some of you guys to have a little, have some ties. But 15-year-old kid, this is one of these, we call this a Z fracture, where you see some of that comminution. And I've historically been a little bit more aggressive in fixing these, but we didn't. It's not shortened. It wasn't poking through the skin. It is his dominant side, but family was amenable to conservative treatment. That's 6 weeks later. You see improvement. All of this, do you guys see that bone down there? That's all healing bone. This is all healing bone, that line right there. And then that's what it looked like at 3 months. Again, a little bit of a bump, but that's better than a plate, better than a scar. And then I did not let him go back at 3 months. I think he was playing something else. I let him play something else, but I hold him out from football closer to that 4-month mark. That's my voodoo, if you will. Another one, 14-year-old male, a little more classic, superior angulation of that medial fragment. This one was shortened, but it only shortened about 15 millimeters. I treated it non-operatively. Again, 3 months later, this is all new bone. It's already starting to remodel, a little bit of a bump. And if I see this, if I took an x-ray at 6 months, that little bump would probably be gone, or it'd be just a little anthill. All right, a couple more. 15-year-old, it's Clemens' kid, about 14 millimeters of shortening. 3 months later, and then this was a Eagle Pass kid. Now this one, a little different, right? 16-year-old, comminuted. So you see this comminution right here, this big butterfly fragment. And in this piece right here, you could see, it wasn't like the alien from Aliens. It hadn't emerged yet. But you could see like the outline of the bone. You could even see the little ridge of the cortex. Very skinny kid, and it looked like it was about to, to prairie dog out of the skin. So I fixed this one. And like I said earlier, this is actually a really fun surgery for me. So it's kind of a shame that we don't fix more of them. But this is, for me, this is kind of a typical ORIF pattern. This extra screw is a lag screw, which I used to fix that butterfly piece, and then kind of built around it with a superior plate. And then one last one, 15-year-old. This kid was also super skinny, shortening 2.5 centimeters, but this medial fragment looked like it was about to emerge. So this is one that I fixed as well. So, all right, great. So we are about 20 minutes in. So before we move on, any questions about clavicles? Yes, sir. Yes, yes. Who, we were talking about this. Who was talking about this? Was it, I feel like one of the schools, maybe it was, I don't know. Where's York? He's not, did we talk about this? Did y'all have more clavicles this last year? I don't know. Anecdotally, I feel like I saw more last year. And I don't know if it was, I forget who it was that we had this conversation. Maybe it was BZ. BZ, are you in here? That's right. Anyway, so anecdotally, I feel like I've seen more. I don't know why, you know, the common things that we chalk up, you know, more injuries to, kids are bigger, kids are faster, kids are playing more, kids are specializing earlier. You know, I think all those things certainly may contribute, but I feel like I've seen an increase. That being said, I fixed less of them because I'm trying to follow the literature. So when I look over the last 10 years, I'm fixing fewer of these, even though I'm seeing more of them. So, good. Yes, sir. Yeah, that's a great question, and I should put that in there for next year. So I think indications to go to the ER. If there is concern for obvious, so absolute, open fracture, neurovascular compromise, you know, when it comes to the clavicle itself. I think the other thing, I talked about associated injuries earlier. Clavicle's really close to the head. You got to think about concussion head injury, right? So that's a given. I think open fracture, neurovascular compromise is a given. That's an absolute indication. The other, and I've got this here in a minute. The other thing is if you have a weird presentation and it's just not adding up. So a good example, we had a kid earlier this year, shoulder pain, posterior pain, got hit, but pain was persisting. Kid ended up going to the ER and having a scapula fracture, right? So I might add, if it just doesn't seem right, if they have tenderness at the SC joint, that's another good reason to go get imaging. But if it's kind of a classic, they got hit, no head injury, a bump, obvious clavicle fracture, pain well controlled, neuro intact, I think that's completely appropriate to give us a heads up so we have a good handoff, see him in clinic in the next couple days. I don't know. Any other thoughts? Anybody else in the room with other indications or contraindications or other thoughts? Yes.
Those fractures were more than like that 3.6 or whatever.
Yes.
More than that. You have great immunity. What are the implications if it happens almost exactly like that again?
So if they break, it heals and they break again, I think you go down the same pathway. Yeah. And I've had a couple kids who break, you're treating them non-operatively, they're 6 weeks along, they're doing well, they do something dumb, they re-break through the fracture. And if they still meet those indications, we just kind of restart the clock. Yeah. Good. Anything else, guys? All right. All right, so next condition. So I basically put in here the 3 most common things I see in young athletes. So a little different. So Little League shoulder. Have you guys, I know a lot of y'all are in here high school, but obviously you've taken care of middle school kids. Have y'all seen Little League shoulder, proximal humeral fasciitis? Great, awesome. And this is kind of the time of year, right? I see a lot of these this time of year because you kind of have that overlap of, hey, I play travel ball, school ball is starting, I played football, by the way, and it's just kind of adding up. So Little League shoulder is kind of the colloquial, I have a hard time with that word, is that the right word? Yeah, thank you. The colloquial word for proximal humeral epiphysealysis, or probably more correctly, physealysis. It's injury to the physis, to the growth plate. It's a failure or a stress fracture through that proximal humeral growth plate. It's due to repetitive, usually rotational forces. We see it most commonly 12, 14-year-olds. The first story parents will tell you is he was pitching, it was Saturday, it was his second game of the day, and he felt shoulder pain, right? And you ask dad, hey, had any pain before this? And dad's like, oh, no, he's fine, we warm up, blah, 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 blah. And then usually you ask the kid, how long has your shoulder hurt? And the kid will usually say, yeah, it's been hurting for 4 to 5 months. So the classic story for me is kind of subacute pain. It's been going on for a while. And then they have one incident that kind of brings it to the surface, if you will. A lot of times they'll tell you, hey, I rested. And you're like, all right, how long did you rest? I took a weekend off. Okay, great. So a lot of times they will have antecedent pain, tried a short period of rest, but then there's one event that kind of brings it to the surface and brings them to your office. On exam, they usually don't have swelling, they don't have deformity. If they have deformity, you should be worried about something else. They will have tenderness. Usually their tenderness is right over the proximal humerus. It's not biceps, it's not AC joint, it's not posterior glenohumeral space. It's right over the proximal humerus. Just like your throwers, your older throwers with slap tears, internal impingement, a lot of these kids will have loss of internal rotation and posterior capsular contracture. That's something important to address in your rehab. And they'll also usually have pain with resisted external rotation and abduction. The classic x-ray finding is this. They get widening of their growth plate. It usually starts laterally because of the tensile forces, but you'll start getting widening of the growth plate. It'll look gnarly, it'll look kind of sick. If it's chronic, you'll start seeing some bone formation where the body's trying to heal it. Callus formation, new bone formation. We certainly get contralateral film sometimes. I don't think you need it with this. This is clear as day. But if you get a contralateral film, you can kind of see the difference between the two. So the treatment is first and foremost rest, right? It's rest from throwing, avoiding any rotational activities that involve torque. You guys have seen this. Kids are knuckleheads. I tend to err on the conservative side. I tell them you can't throw, you can't hit, you can't lift. I know that whatever I tell them, they're going to do a little bit more, so I go on the conservative side. That's just kind of my strategy. But I have them avoid any throwing, any heavy lifting, any hitting, certainly no contact activities, and I want to see them pain-free for about 6 weeks. I tell these kids, if they have pain and they go back to activity, the pain is not magically going to go away. It's not going to go away with activity. So I want them pain-free for at least 6 weeks. And then we begin physical therapy and rehab with you guys. Now, a lot of therapists will focus on the shoulder. They do, rotator cuff strengthening, scapular stabilization. But I really think the bedrock here is core and lower extremity. We know, you guys see this. This is a picture of my son. And I like this picture because he's 12. He just turned 13. But he's like tall and he has no legs. He has no butt. And this kid is like the classic setup for Little League shoulder. Because he's 6 feet tall, he's going to go out there, he's going to try to muscle it. He's going to, he's like, hey, I'm throwing 85, like whatever. But he's not using his legs. He's not using his core. And if you're not doing that, all that force is transmitted to your shoulder and your elbow. So I think a huge part of rehab is working on lower extremity strengthening, core strengthening, because that's where all your power comes from a pitcher. Have you guys seen that? I know you guys have seen that. Great. We do PT and rehab. Usually begin a return to throw program after about 6 weeks. I tell kids if they've got this x-ray picture, the season's probably over. It's probably going to be a 3 to 4 month recovery to get them back to full baseball activities. The other great resource, you guys probably have this, so looking at Pitch Smart, There's, it's a great one-stop shop for pitch count recommendations, good warm-up recommendations, and good literature-based, evidence-based recommendations on, preventing these overuse injuries. All right, anything on that? Yes, sir. Yeah. So, yeah. So I think that oh my gosh, return to throwing program is really important. That website I showed actually has some good examples. And I played high school baseball, but I've been out of it for a while. The return to throw programs are great. It's very specific. You throw 10 throws, from this distance, then 10 from here, then 10 from here. That's it. Next day you do this, next day you do this. So I think that's important. The other thing I tell these kids, not just Little League shoulder, but UCL sprains, medial epicondyle fractures, capitellar OCDs, the spectrum of injuries for a throwing shoulder, or for a throwing athlete. The other thing I tell them is, your first season back, can you play anything else? And a lot of times these kids are like, yeah, I can play first, I can play shortstop, great, do that. Get a season under your belt playing something else besides pitching. Get through your season, continue rehabbing, continue building your strength and your confidence, and then go back to throwing. And most kids are amenable to that, especially if they're 8th grade, 9th grade, 10th grade, right? Most kids are okay with that. So I think that's a good strategy. Try to get them to play something else for a season before they go back to the mound. Yeah. Yeah. So, all right, guys. All right, I think we got 10 minutes left. So, and we're going to kind of work through this. Shoulder instability. Again, shoulder dislocation, shoulder instability, very controversial. We could have an entire week-long symposium on shoulder instability. There's so much to unpack here. I'm going to give you guys kind of my take on shoulder dislocations, labral tears, shoulder instability in the high school athlete. I'm going to tell you why I do what I do, and then we'll move on. So anterior instability, most common, it's more common than posterior instability. We see it contact collision sports, that typical mechanism, forced abduction, external rotation. We know that the humeral head translates anteriorly, and that's where you get that labral tear, Bankart tear. I'll show you that here in a minute. Big points for you guys. Think about the axillary nerve, good neuro exam, sensation laterally, deltoid function. It's important to look at that. For the kid with chronic instability, we think about the Beighton score, which is a good marker of their hyperflexibility, their hypermobility. The tests that we tend to do more of these in clinic, that anterior load shift, the sulcus sign, but then the classic one that we do is the apprehension test, and I know you guys have seen this. So you have the patient supine, apprehension, put them into that at-risk position, and they'll feel like their shoulder's about to come out. They'll say, hey, it hurts, it's weird, feels funny. The relocation test is you apply an anterior pressure, and that sense of foreboding goes away. And then the third part of the test is the surprise test. You take your hand away, and then it surprises them, and they feel that apprehension again. So this is kind of the meat of this. So predictors of instability, of recurrent instability. You've had a kid, you have a junior, shoulder dislocation. What are the risk factors that they're going to have continued instability? These are the most common ones. Age. We know age is a huge risk factor. These are some of the classic studies. Recurrent instability, 94% in patients under the age of 20, 61%, 87%, 72%. So we know, and I use the number of greater than 50%. If you're a young athlete, you've had one dislocation, the chance of you having another dislocation is more than 50%. The only thing that's a little caveat, it's a little interesting, is in the very young patients. In the 9-year-old, the 10-year-old, the 11-year-old, those kids will actually break their proximal humerus before they'll dislocate. So if you have a 10-year-old and you're like, I think they dislocated their shoulder, they probably broke their proximal humerus. It's not impossible that they dislocated their shoulder, but fractures are more common. We do know that in those skeletally immature athletes, their risk of recurrence is lower for whatever reason. In the skeletally immature, if they dislocate, their risk of recurrence is not quite as bad as the 15, 16, 17-year-old. activity, so contact sports, have a much higher risk of redislocation. If they have a bony defect, if they have a bone defect to their glenoid or their humeral head, if they are male, or if they have ligamentous laxity. So the Bankart lesion, you guys have seen this on MRI reports, you've heard about this. The humeral head translates anteriorly. It tears the anterior inferior labrum and the inferior glenohumeral ligament. And we know that about 90% of first-time dislocations will see this. This is what it looks like on the scope. This is kind of a gnarly one. This is glenoid, humeral head, that's labrum. So bad labral tear, and I'm not up there. Anyway, so bad labral tear and a glenoid bone injury as well. Hill-Sachs lesion is an injury to the posterior humeral head, again from that dislocation event. So bone loss, your glenoid, the socket of your shoulder, the more times you dislocate, the more damage you do to the bone. Now this is important, and this goes into why I'm aggressive with these. Your best opportunity surgically to take care of this patient is early. If they have dislocated 5 times, 6 times, 7 times, every time they dislocate, they knock off a little bit more bone from that glenoid. That makes your chance of success with surgery a little bit lower. We know that about 80% of patients with recurrent dislocations will have significant glenoid bone loss. So this question comes up every year, right, for all you guys. I dislocated my shoulder, I want to go back. What's the protocol? What are the steps for in-season return? So I think if you have an initial shoulder dislocation, no bone defect from the glenoid or the Hill-Sachs, no IGHL or Hagel lesion, you can think about in-season return. So much of this comes down to the athlete, the parents, where they're at in their career. You guys have all seen it. You'll have a senior that's not going to play at the next level. They want to get back. Family's okay with the risk. Okay, let's do it. But you have to think about those factors. You have to think about all those things as you make your decision. A lot of people say non-contact position or sport, right? That automatically excludes every football player, right? That's kind of a soft indication. They have to be able to complete their position, sport-specific drills without instability. They have to have full and painless range of motion. If they hit all of these or most of these, then maybe you think about in-season return. This is my kind of non-operative protocol, trying to get them back in season. Again, I don't advocate this for every patient. This is for that rare kid that it's very important for them to play their senior year, and you're trying to get them back. So sling, 1 to 3 days, cryo, gentle range of motion. Once they have full painless range of motion, you progress to shoulder stabilization, cuff strengthening. Once they have symmetric strength, you progress to sport-specific exercises and give them a go. This is a pretty classic paper. This is out of West Point and Annapolis. They talked about their experience in season, dislocation, trying to get them back to full sports. The bottom line, they got 73% of the kids back, but 64% of those had subsequent instability events. Only 27% of them actually made it through the season without any instability, any subluxation or dislocation. So you can try it, may or may not work. So back to that patient, 16-year-old, first-time dislocation. What do? Do we do surgery up front, first-time dislocation, or do we rehab them, see how they do? This is a great meta-analysis, 21 studies, 5,000 kids, 5,000 patients, 87% male. The operative group that had surgery after their first dislocation had a 16% incidence of recurrent instability, 85% return to sport. The non-operative group had a 25% risk of instability and a 78% return to sport. So again, you treat them operatively, much lower risk of recurrent instability, higher chance of return to sport. So for those of you guys who know me, I'm not aggressive about a lot of stuff, but I am aggressive about these. When I have a contact athlete, first-time dislocation, labral tear, I always get an MRI, I do. And again, you ask 10 different docs, you'll get slightly different answers. This is why I do what I do. First-time dislocation, labral tear, contact athlete, I offer surgery. I don't mandate it. I just had an ice hockey player who didn't want surgery. We rehabbed him, and he's playing, and I hope he does great. But I offer surgery for first-time dislocators because I know in the high school athlete, non-operative treatment has a high failure rate. There's always something to fix. That something to fix only gets worse with more dislocations. The more times they dislocate, the lower the chance of success with surgery. And the more times they dislocate, you may get to a point where you can't fix them arthroscopically. You have to do a open Bankart, you have to do a Latarjet, a coracoid transfer. So the more times they dislocate, tougher the surgery, higher risk of surgery. And then this is just an example, recent example of one of my labral tears. That's the tear, that's the nice repair. You restore that bumper, retension them anteriorly. It's much easier to do it after one dislocation than after their fifth or sixth. All right. Sean, are you in here? No, not yet. All right, you guys give me 3 more. Can I have 3 minutes? 3 minutes. All right, last thing I want to show you guys, SC dislocations. Who has seen a sternoclavicular dislocation? Great. So a couple people, right? Couple people. They're not super common, but I want you guys to think about them. So let's move it. Oh, that means I'm done. All right. So this is actually this is from last year. This is actually a Reagan kid that had a football injury. So sternoclavicular dislocations are sneaky. The reason why they're sneaky is you can't see them on x-ray. You usually have to get a CT scan. If it's obvious, if it's this kid, there we go. This was a kid from Florida, trauma center. She was on an ATV, got hit by a truck. This is her left clavicle. That's her right. Can you guys all see the difference? Yeah, that's bad, right? But it's not always that obvious. This is the Reagan kid. So got hit, pain here, actually came in a day or two later. This is, there we go. All right, so sternum, left clavicle, that's actually okay. Right clavicle, do you guys see that? What's that thing right there? Do y'all know what that is? That's your trachea, right? So this kid, there we go, 11 millimeters from the trachea. And then, do y'all know what this thing is right here? Yeah, it's the heart. And then this is the aortic arch. So it's like a couple millimeters from the aortic arch. So if you have a kid, gets hit, tenderness, always think about the SC joint. If they have pain, deformity, swelling, think about the SC joint. If they have voice changes, dyspnea, stridor, difficulty swallowing, any of those things, that is a call 911. It's not a call me. You can call me after you call 911. It's not a go to clinic. That is a call 911. They go to the ER immediately. I will never ever criticize any of you guys for sending these to the ER if you're worried about it. You don't want to miss it. The reason why these are so important, you can get medial compression, or you can get compression of the mediastinum. We have to reduce it, fix it, or it can be very bad. Any questions about those? Sorry I ran over. Any last minute questions, or I'm going to stop? Perfect. All right, guys. Thank you all. You all have a great day.